welcome to the future of long-term care for seniors in Simcoe County. We're very pleased that you're joining us by watching your TV screen, or you're on your electronic device and you've streamed into the Rogers website or the Facebook Live site. I'm Keith Rose, your moderator for this, our 36th Our Health event. Just some comments to start. The COVID-19 pandemic has unmasked many weaknesses in long-term care homes that resulted in, unfortunately, preventable deaths and horror stories of care that was lacking. Several of these issues that led to these outcomes actually predated COVID. Just a couple of statistics. Ontario currently now has over 100,000 long-term care beds. If you look at who's occupying those beds, the residents, half them are over the age of 85. Most have dementia, and many have medical illnesses and physical disabilities. It's difficult to estimate, but somewhere around 1 in 10 older seniors will eventually require the services currently offered by long-term care. Now it's my pleasure to introduce tonight's 4 speakers. Jill Knowlton. Jill, just put your hand up there. Okay, Jill is the Director of Long-Term Care Operations for the Gillette Health Services. Jonathan Enns is the Administrator at Hillcrest Care Village. Oh, I always get this mixed up, John. Hillcrest Village Care Center. I turn it around, sorry. I'll do better. Jane Sinclair. Jane leads the Health and Emergency Services team for the County of Simcoe and has oversight for the 4 Simcoe County's long-term care facilities. Jane's actually a repeat participant on our show. She was here in June for Aging Successfully, and welcome back, Jane. Ted Chivers. Ted's a baby boomer and a local resident who's given a lot of thought to his next chapter. And he wants to discuss various aging in place options in addition to the traditional long-term care model. So welcome to all of you, and I look forward to our discussions. But before we begin, I have a few thank yous. First of all, to the Our Health Advisory Committee, 6 very committed people. And specifically tonight to Kathy Wolfer, who did the lion's share of putting this program together, working with the speakers and working with Ted and I throughout the last 3 months on this program. I'd like to thank our 7 local sponsors, and a little later on in the program, I'll acknowledge them separately. And of course, to the extraordinary staff at the Midland Cultural Center and at Rogers TV, who without their diligence and work, this wouldn't be possible. During the first hour of the program, we're going to hear from our 4 speakers. With some broad brush strokes, we've identified 5 themes that we think are important when looking at the future of long-term care. There's some overlap, but they seem to work pretty well. So those 5 areas are resident care, including infection prevention and control, staffing, funding, structure of the facilities, and lastly, other options to consider rather than the traditional long-term care model. Now, each of the speakers has agreed to introduce one of these topics, and then we're going to have all of them join in for the discussion of those topics. There will be an opportunity during the second part of the program for more specific audience questions. Please continue to forward those questions during the show to the address that's on your screen, mcc_ourhealth@outlook.com. And of course, for those who are on Facebook Live, please continue to send in your questions. One thing's a little different tonight. Towards the end of the evening, I will be asking our guests to summarize their suggestions for the future. So we leave you with some pretty key points that we think are important. Well, I don't know what they're going to tell me yet, but that is the plan towards the end of the evening. Jill, did you agree to go first, or did you get assigned this project?
I was assigned, Keith.
She's agreed to begin the talk about the care of the residents in long-term care. Jill, to start, can you give us a brief overview of long-term care? How do you define long-term care? I know we always frown on acronyms, but LTC is a pretty common acronym, so I think we'll allow it tonight. But give us a brief definition. What are the residents' health needs and the current type of care that they receive? And then where your real area of expertise is, what's going to look different as we go forward?
Okay, thank you, Keith, and good evening, everyone. And what a great opportunity to talk about such an important topic tonight. Long-term care in Ontario is largely an institutional model. If you ask somebody on the street, you stop somebody on the street and you ask them, what is long-term care? They'll likely tell you it's the home down the street or the home down the road or the place where my grandmother lived. And yet, we know that these buildings have tremendous variability to them as well. So, Jarlette is going to be opening at the end of the year a brand new 160-bed long-term care home that's a modern facility that will provide state-of-the-art care and services. And we've got homes that are still operating as long-term care that were built in the 70s that had the 3- and 4-bed wards, the narrow corridors, problems with accessibility for washrooms, and challenges around dining. Ontario, with its definition around institutional model of care, probably needs about 100,000 new long-term care beds. And we know that that's really unrealistic. First of all, who's going to build them? Secondly, how can we afford them? And where would we ever get the staff to operate those? So this is where Ontario, when you look at other leading countries in the world, such as Denmark, Sweden, pockets of Japan, I would say, where long-term care, the definition is different. It's around a continuum of services for adults requiring the services. It's a basket of services, and society organizes itself around and values older adults, and so choice is built into living, and it's much more normalized in society. So Ontario continues to look at it as an institution instead of a continuum of services. Long-term care, however, is very unique in the health system, and that it's the only sector that is both a care facility, but equally, if not more importantly, it's also someone's home. So when we look at long-term care, we have to contemplate quality of care, but we also have to contemplate quality of living. And those who live with us are much more frail today with highly complex medical and social needs. But long-term care.
Jill, I'm just going to interrupt you for a second. I was reading somewhere that the average length of stay in long-term care is about 2.5 years. And I think for long-term care, that means that is the end of life for the majority of those people. But I think it gives you an appreciation of just how sick those patients really are. I mean, Jonathan, in your career, you must have noticed a huge change in the type of people you used to admit 15 years ago versus what you admit today.
Certainly, it's drastically changed. We used to have residents that were with us for 5, 7, 10 years, and now it's, like you said, it's drastically come down, and those are more the exceptions than the norm now.
Okay,
people that have been with us for a long time. So
Jill, sorry to interrupt you. Carry on.
That's okay. That's an important point.
I'm good at interrupting, Jill, so just cut me off.
Okay. So long-term care is largely structured around the medicalization of care and services. The quality framework is focused on medical interventions, standards, checklists, sort of the over-routinization of care that often undermines residents' own preferences. Long-term care also sits very siloed to the rest of the health system. And I think this was the great reveal through the pandemic, or the great learning from the pandemic, was that long-term care sat over by itself. Over here, people who knew about it were those who had an opportunity to have interacted with it, but others didn't really know what long-term care was. It has its own ministry away from the Ministry of Health. So the rest of the health system sat very separate from long-term care. Even Ontario health teams that have been implemented had excluded long-term care. So there's been a lack of connectiveness and collaboration with health and social service partners. And although there has been pockets of innovation in long-term care, new models of care are really just that, new models of care with very limited uptake and adoption. Yet there are glimmers where there is leadership and innovation. And I would suggest just hearts and minds in the right place and a tremendous amount of will, where you see the type of homes with exciting programs and exciting places to live starting to come through. For example, homes that have implemented emotion-focused care philosophies, such as the butterfly model or Eden and greenhouse models, or other models such as really intensive mental health programs in partnership with hospitals, where adults that maybe would never have had an opportunity to live outside of a hospital now have a home in long-term care.
So, Jill, can you give us an example? Well, first of all, being able to get outside of the hospital to see something is a good example, but what other examples, like what's the model today versus a very specific what you're thinking it's going to look like once you implement the butterfly model?
I think so. Very traditional model today, and I would say really over routinized care that focuses on, I always call it the list. So people are lists. You're on the doctor's list, the foot care list, the low fluid list. You're always a list or you're a number. And really when that's a very traditional approach, and when you move away from that and you look at relational care or emotion focused care, the hierarchy drops, the staff are empowered to really engage with residents and work with residents, where the day becomes really the program. It's just normalized living, and staff really are part of that day. They're part of the family with that resident. So there's much more opportunity to engage, to participate in meal preparation, to eat as a family, to have that choice and make those decisions around, when you might want to go outside, when you want to have a bath, when you want to do the laundry, when you want to peel the vegetables to get ready for dinner. So it's a far different approach. And when you drop that routinized approach, staff actually do better as well. Staff engagement, staff satisfaction is much greater because, again, they're participating in the day as a family member with their residents, and they know them much more acutely than just reading somebody's name off a list and saying, well, that's the next bath for the day. So really fundamental differences and shifts. And we really move from doing things to residents or about residents to being with residents. And that's about being person-centered. And so I often hear when you talk about person-centeredness, people say, well, we're doing person-centered care. Well, you don't do person-centered. You must be person-centered yourself. And that's the big shift in the culture when you move from, again, the traditional model that we have today to an emotion-focused model.
Now, Jill, does this apply for everyone in long-term care, or are you specifically saying those that are on the early dementia course versus those who are on the late course? Is there a difference in how the care is delivered or how you do it?
I think, Keith, when the butterfly model or Eden or greenhouse were first being talked about, they really were focused on those individuals with dementia. But really, as the models have developed and have spread within a home from a dementia-focused approach to across an entire home, it's really about relational care. It's care that any one of us would want, or approaches that any one of us would want to just living well and being treated with dignity and respect, and again, being person-centered. So there's really nothing in those models that any one of us would not say would be really what we would want if we were to enter one of these homes.
Thoughts, Jane? Is this something that you'll be embracing or studying or wait and see at your 4 homes?
No, I completely agree with Jill's comments. She's done a really nice job defining these models of care. So the butterfly model, it's really about getting away from an institutional setting and creating a home-like setting. So at home, we might not all get up and have breakfast at 8 o'clock in the morning. I'm going to confess, I don't start breakfast early. So it's about making the lives of those we serve in long-term care as normal as possible. So if I want to eat breakfast at 9 o'clock or at 10 o'clock or just have a light something to eat, then that's okay. And that will be incorporated into my plan of care. So it's really about making as normal and home-like as possible. These are wonderful philosophies, and I think we're all starting to adapt these various types of models now to make it as much as a high quality and home-like as possible. So we'll continue to do this, and we hope that the structure that we work within in long-term care really allows that flexibility for our staff to be flexible with the needs of those that we serve, and adjust their routines and the environment, introducing color and textures to really provide that wonderful sense of home and support for these individuals that we care for.
Okay. Jill, do you have something more to add, or is this a good time to segue into the staffing issue?
I think I just want to make one more comment, that because I think it's something that Jane mentioned, is that the regulatory regime today often has to be overcome in order to implement these models. Now we've learned and over time and worked with other experts to be able to do that. But again, the current regulatory approach really favors that highly prescriptive, paternalistic approach to care. And what we're saying with these new models is that that's what needs to go, right? This needs to be about people's personal preferences and choices and being person-centered and being supported to live well. So, one of the opportunities that we have right now is with Minister Phillips has been out speaking fairly regularly that around and consulting people around the opening up of the Long-Term Care Homes Act. And we will see some changes to the Act this fall. So this is a tremendous opportunity for us to sort of drop that highly prescriptive approach. And again, it's not only about quality of care. I think equally or more importantly, it's about quality of living. And that's what needs to be entered into into the Long-Term Care Homes Act as it's modernized.
Thanks, Jill. We'll come back. You'll have lots more to say, I'm sure. Jonathan, you're going to talk a little bit about the staffing. Perhaps you could start with the current model and the changes that have been recently announced, and then kind of follow from Jill's comment. If we do implement patient-centered kind of care, I'm going to call it that, emotional-centered care that's very unique to each individual patient's needs, does the staff have the wherewithal to do that? Will they have the time to do that? So I'd be really interested in your thoughts on this.
I think Jill touched on it. It's in the current regulations and funding, it is very tough. And of course, we do our best to focus on the residents' needs individually. But again, because we're in a home area, Hillcrest has a home areas of 24, 26, and 32 residents. It's, you also have to consider how we're going to care for them as a group as well. And that's, for staffing, we've come a long way from where we have been. And in the last year, as it's been noted, we have a long way to go in order to make sure that we are supporting and providing what residents need where they're at, in their care continuum. So, so staffing currently is, we have RNs and RPNs that are on the floor and providing medication and daily wound care or other specialty need care. And then of course we have our PSWs and nurses aides that are the front line, the hands-on with helping the residents every day, every hour with activities of daily living, getting them up in the day, getting them to the dining room, helping with food service, and then making sure that they get the nutrition they need. All of that is what the PSWs and nurses aides do on a daily basis. And then the pandemic has brought to light that there is room and there is a role for what I think some homes call resident support workers or resident support aides, and maybe not as direct hands-on care, but doing that supportive care for the PSWs and the nurses aides. Because the other thing with staffing, as has been highly noted in the media, is that staffing is a very tough. Having staff come to long-term care is very tough at this time, and it was already tough before the pandemic. And this has really just highlighted the or stressed the staff that are in the system, and students and other people looking to join into long-term care.
So, Jonathan, given that the ministry's already announced, or I think they're going to go to 3 hours of funding for the next 6 months or 8 months, and then 4 hours of care funding for thereafter, and they've announced that, and I think they've agreed to send the money. So that's a really good news story. But in the meantime,
certainly is.
You've got to find the people, you've got to train the people, and you've got to kind of turn things around. And to be honest, when somebody says, well, everybody gets 4 hours of care, I think, well, if that's pretty regimented, if we're going by individual needs, it's going to be quite variable in terms of who needs the most care, and to sort some of those things out, right?
Absolutely. It certainly is. The current assessment model, you can have residents that need very little care and residents that need complete help with whatever they need in order to live. And so, you're right. It's the 4 hours comes across as an average, but then there's some that get less and some that need that would receive more care. And that's currently how it works as well, right? With the just under 3 hours, and hopefully we'll be able to get to the 3 hours in the next year. So, and that of course will stress our recruitment system, and so staffing is going to be a challenge to get people drawn into to want to work at long-term care, and it used to be that the want ads in the paper and people apply and you hire them and give them training, and that's changed for the better for care, as more training was required and the PSW program. And but a lot of people aren't looking to be a PSW for long term, and they're looking to be maybe an RPN or an RN or dietitian and different things. Long-term care is almost seen as a stepping stone to going somewhere else in a work career, and really it's very fulfilling work to provide care to help people that need, and so it's trying to promote that and recruit with that in mind.
Well, I assume that you'll be in competition with the other two speakers here in terms of well-qualified people to fill the roles that you actually now have the funding to hire for and to train them sufficiently. How is everybody going to manage this? Are you going to put training programs together of your own to make people want to come to your organization? What are you going to do, Jane?
So that's a great question. And right away, I start to think about partnership with our community colleges and with our local high schools. There are great opportunities. And, the province has, put forward a number of new, fairly recent programs to incentivize people to get into long-term care, get into the sector, providing tuition aid and creating bridging programs so that you can kind of start your career at an entry level and work your way through. And so, I think a big part of this for all of us, and you're right, we're all competing for the same valuable resources, is really working with our partners in the community to educate and train students and give them a really positive experience in our long-term care homes. I started my career as a nurse in the hospital sector. I didn't know what long-term care was about until I found myself working in a long-term care home. And I was, quite honestly, I was shocked. It is an extremely fulfilling role. The care that you provide, the staff in long-term care look after these residents like they're their own family members. And so we need to all work together to get the word out there. What a positive and fulfilling job it can be working in long-term care. And really, I think, partner with our educational facilities to create opportunities to get folks into our homes and see that positive experience and feel that, that great feeling when you're caring for someone and you're making a difference in their life every single day. And that's how we'll be able to, I think, recruit and retain a workforce for the this amazing announcement about the new funding for long-term care.
One of the challenges that some of the reports on what happened to long-term care during COVID highlights the lack of consistency of staff. And this happens because staff apparently work on several wards potentially, and therefore they might not know all the patients very well, but they do provide the care, but also that they might work between long-term care homes, and that sometimes refers to the part-time model. How are the three of you going to address those issues, which I think all of us can say, yeah, I can see if I had a different caregiver every day, I might not be too happy, or if people are coming in from an infection control point of view and they work one place and another place, the challenges, that was a problem during SARS. Who wants to handle that? Jonathan, do you want to take a start?
Certainly. The goal is to offer full-time, as much full-time as possible, in order to have that consistency in where people are working. So we have 6 different home areas in our home, and we'll have 5 or 6 dedicated staff to there. But you're right, they can't work every day, and there's extra staff that need to be there to relieve for days off, and that's where the part-time role comes in. And but there's also a matter of making sure staff stay engaged and maybe offering them the opportunity to move to different home areas where they can, it's good to know residents, but especially with dementia care, it can be very challenging if there are certain behaviors that are very challenging. And so it's sometimes good to have staff switch, every year or so and give them a different challenge, give them new people to care for. And that's, a model we've done to help try and keep staff, from burning out and from, giving them that new stimulation of learning new people to care for, new different challenges than always the same. Same. So we do offer full-time, and we do have the part-time to help fill in. And the pandemic has certainly, as you've mentioned, or that it's part-time working here and at other homes is very challenging. But of course, you do need to have that part-time pool, and all homes will need it. I need it in order to cover
So talking about the
vacations and absences.
Extra available staff, I think one of the criticisms leveled by some of the reports is that when staff got sick or felt unwell, then there wasn't enough staff. There just wasn't enough staff. And so, of course, the Pollyanna people at the top say, well, we need a pandemic plan that addresses what are we going to do if we have, a whole cadre of nurses phones in sick someday. Have Jill, I'll take Jonathan off the seat here and say, are you putting in place pandemic planning that talks about a backup plan?
Absolutely, Keith. I think for every position, every department in the home, we have a contingency staffing plan so that we understand sort of the lower level we could get to with staffing and how we spread out the work. If we drop down one nurse, for example, or two nurses, and then also our ability to bring in staff through some of the agencies, for example, contingency contracts with them to be able to supply healthcare workers for us if we did get into a situation similar to what happened in some of the homes with the crisis in the pandemic, where they lost upwards of 80-90% of their staff within a matter of a couple of days, and that's beyond a crisis. I think working with our Ontario Health regions around the MEST teams, those would be contingency staffing teams that what we used to call the LIN, but Ontario Health now works at putting together. But I do think maybe a little bit different than perhaps your comments, Jonathan, is, I think through the culture change with emotion-focused care and using the butterfly model, you begin to understand that staff are a family with the resident. And so you live and you work with your family. And what is a family? The term we learned through pandemic was cohort. Well, your cohort is really your family. So when you stay with your family and you stay in your cohort, you're not sort of spreading, if there's something going on in that home area, it stays in that home area with that family. So sort of shifting that and maximizing full-time employment, and also looking at the schedule differently. And so we know that the workforce of today has different needs and wants. And so where traditionally, we may have scheduled, we may have been looking at what we would call a normalized schedule that might be, we may have been doing the same sort of approach for 20 years, let's say. The workforce of today has different needs around work. And so, we need to be working with our staff, working with our union partners to ensure that we're creating a workplace where people want to come to work and that meets their needs, because we need everyone. We're in a crisis, and we're not going to get out of it. Adding the average 4 hours of care, which we all welcome, and I personally see as an enabler to well-being, an enabler to the culture change that needs to happen. But it's going to take a while for us to get people prepared to be able to take those positions. It's 4 years of university education to train a nurse. And so it's going to take a while to get the numbers to the level that we need. So what are we doing in the meantime? And that's why I say, we need everybody. And I think, Jonathan, you mentioned the resident support aides, or sometimes you hear them personal support assistants. That's a great way to bring people who may be interested in long-term care or maybe interested in healthcare in. They see what goes on, the really highly satisfying work that goes on in long-term care. And then the laddering programs start to make sense, right? They might ladder into PSW, and then the PSW may ladder into RPN. That's how we're going to grow our workforce. But I wouldn't want to overlook the fact, I think your question, Keith, started with around what do you do when you lose a large number of your staff in a crisis situation? But I wouldn't want to not be realistic about the fact that it's going to take us a while to get that workforce built up to the level with the programs that are in place where we can actually get up to that average 4 hours of care. So I say everybody, we need everybody. Sorry.
I think in my conversation with both Jonathan and Jane early on, you both had some kind of unique staffing. Jonathan, you had access to some international trainees, and Jane, you pulled in some of your workforce from other areas in your portfolio that actually hadn't worked in long-term care, or that wasn't their primary jobs. So maybe you just want to discuss that for a second.
Sure, I can start if you like, Keith. We were very fortunate when the pandemic hit. There was almost immediate needs to increase what we were doing in our long-term care homes, increased infection prevention and control, screening, cleaning, more PPE, and so we found ourselves immediately needing more resources. And across the county of Simcoe, the opposite effect was happening in some of our other services, where things were pulling back because the infection was spreading. And so we were able to redeploy staff from other areas across the corporation, from library services and roads and waste management and Ontario Works, and it was tremendous. We had over 100 of our staff from other areas across the corporation who came to work in each of our 4 long-term care homes, put the scrubs on, were trained and helped assist, dug in, and it was a phenomenal experience. It was an eye-opener for those corporate staff that hadn't worked in long-term care, and I can tell you our long-term care teams couldn't thank them enough for being there to lend a hand. So that's how we started. We were very fortunate, and since then we actually developed a role called, we call them home services assistants, and it's kind of an entry-level position that we hired, recruited into the long-term care homes that are, assisting with some of those areas around, the screening and the infection control precautions. And so they've really added to our team. And I can tell you that many of the folks that did not work in long-term care previously love it and have started down new career paths to look at different opportunities, whether it's dietary aides or personal support workers, et cetera. So, it's been a great opportunity to build our team and to work as a much bigger family.
Great. Jonathan, very quickly on your approach, or one of your approaches to the international space.
Over a decade ago, we had an international staff member who wanted to come to Canada and reached out to us, and we were able to help move him and his family over. And from there, our program grew, where it's been over the years developing, and now with the pandemic hitting, we've joined with an agency to help us do recruitment that way. So, again, it's bringing in international or new Canadians to come in and help provide the care. Or, in our case, we've actually found newer Canadians that were already here and were trained in another country, but willing to come and work as nurses, aides, PSWs, and then having them come alongside and join our workforce.
Great. I think we could go on for a while with staffing, but I'd be remiss we have some other areas we wanted to touch on. Jane, tell us about the money. Tell us the current model of who pays for what. And I know it's very different than going into a hospital. You actually patients have to pay something in long-term care. And then what you see as if more money is coming, where are you going to put it? Where are you going to put that money? Where's your priorities?
Okay, great. So I'll break down the, funding and finance is always an exciting topic, I'm sure. But what I'll do is I'll break it down and I'll talk about the accommodation. So it's really twofold. So the residents in long-term care pay monthly accommodation fees or rent. And then there is a portion that is funded directly by the province of Ontario, by the Ministry of Long-Term Care, for the care and services provided in the long-term care homes. And so when I look at the accommodation fee, so the amount that each resident pays, it's standardized. It doesn't matter whether the long-term care home is owned by a municipality, whether it's a for-profit, not-for-profit, charitable, the fees are standardized. Everyone in long-term care pays the same rates. So for a basic room in a long-term care home, it's just under $1,900 a month. $1,891 is the monthly fee. So that's what each resident would pay per month. And
that would be the total extent of what they would pay, right?
That's the total amount for a basic room. And I will tell you that there are a number of individuals who pay basic amount that are actually subsidized over and above that. So if an individual doesn't have the income to pay even the basic amount, there's a process where the home will review their tax notice of assessment and complete a process. And then if they qualify, they will be subsidized. So, it's available really for anyone in the system, regardless of their income. So there's the basic rate and subsidized basic. And then there are another category, which is called preferred accommodation. And we offer either a semi-private or private. So semi-private typically is homes that have rooms that have their own bedroom, for example, and may share a bathroom. That might constitute as a semi-private room. And so there's an additional fee for a semi-private, and that ranges, it depends on the age of the facility, from $2,100 a month to $2,200 a month, roughly. And then there's full private accommodation. And so those are rooms that have their own bathroom as well. So they're totally private rooms. And then the fee, again, depending on the age of the facility, range from roughly $2,400 a month to $2,700 a month. And so whether a long-term care resident moves into one of our facilities or Jonathan's or Jill's, they're paying the exact same rates for those types of accommodations. And then the only
our audience needs to know is that for anybody who really does fit the classification of needing long-term care, money will not be an object in their care.
That is correct.
Somehow somebody will find the money, whether it's subsidized from social services or whatever, they'll be able to pay. Now, they might not be able to have a private room, but they can do the other stuff, right?
That is absolutely correct. So it is available. It doesn't matter what your income is. And so it works very well that way. So for those that, don't have enough each month to pay the basic accommodation, they will be subsidized. So it's great to see that there is a process for that. And the only other type of accommodation, and I'll mention this because a lot of folks don't understand or realize this is offered. It's called respite or short stay accommodation. So many long-term care homes offer this short stay. So that's for an individual that lives in the community where their family member that's caring for them may need some respite, may have to travel or have some obligation and can't care for their loved one. And so they can place that individual in a long-term care home for a short stay. And the rates are based on a daily rate. In that instance, it's $40 a day. So there is accommodation for folks on a short-term basis as well that live in the community. So those—
I'm going to ask you the really difficult question. You've outlined a very tried and true system that long-term care is used for funding, and it's so common. I think most people understand it now. I hope. But should we change it? And if so, what should it look like? What would you, if you were the people making these decisions, is there something that's better, or do we leave it the way it is?
Well, one thing right off the top, when you ask me, I would focus on that short stay piece. I think we need to communicate, do a better job communicating it to individuals living in the communities. I think it's sometimes it's one of the best kept secrets. When it's utilized, people in the community love it. They appreciate it. It works very well. It helps actually keep people in their homes, in the communities, having that opportunity for short stays. But I think there's an awful lot of opportunity to utilize that even more, to reach out to people, to offer that service. So that would be one item right off the top that I would certainly recommend, that we could probably do a better job in our communications and marketing for those types of services, because that will really help people keep people in their homes. For longer duration. So that's one component that I think jumps forward. And the other piece that I would say,
sorry.
Oh, I was just going to say that the split between basic and preferred accommodation. So the regulations have been each home typically will have a 40% basic, 60% preferred accommodation split. And I know more of the newer developments are starting to increase the amount of basic accommodations, because what we see on our wait lists tends to be a higher need from the community for basic accommodation versus semi-private and private. And sometimes the facilities are filled with their basic beds, and so there's more people waiting for those types of accommodations. So I know that certainly has been flagged across the province. There tends to be a growing need for more basic type accommodation. So
help me
that would be
understand,
one.
does this mean then we're going to have more patients in 4-bedded rooms with sharing bathrooms?
No. So that's
Okay.
a great question. So the current standards in the redevelopment, we're not building 4 bedrooms. Those are the older designs. And so the province has been moving to eliminate those types of beds, and will continue to do so till they're completely eliminated. So
Okay.
any new beds being developed will be, the maximum would be 2 people in a room. So it'd be 2 or 2 people sharing a bathroom, or then individual rooms. So.
Okay. Jill or Jonathan, anything to add around the funding piece?
I would probably look at it a bit differently and say extend long-term care funding to retirement homes and other sort of residential living settings. Adult day programs can provide long-term care level services, and then you go home. Where most people want to be is in their own home. So extend funding into those areas. And then really what it would do is shift sort of the lighter end of long-term care, not lighter, but the portion of long-term care into those types of seniors housing as part of the continuum of seniors housing, and save or keep long-term care for that finite subset of individuals who really need that complex medically supported care. And I think that's where we would get better use of our long-term care system, and really appealing or responding to what people are saying they want, is to stay in the community longer and to stay in their home. So I would probably look at it at shifting funding.
I can certainly see Ted Chivers smiling on that suggestion, Jill. I think in terms of people staying at home, making it easier, I think that's a great suggestion, or other than long-term care like retirement homes. Jonathan, anything to add on the funding piece?
I think Jill and Jane have covered it.
Okay, so at this point, I said I would cover the structure, and structure should follow function. So you've been talking about a butterfly model, a model where the patient is the center of care, and it's specific for that particular patient. We've been talking a little bit about infection control and staff. So if we are building new long-term care homes, and I know that applies to at least 2 of you right now, you're in the middle of building, what things should we be thinking about to build them differently? Or Jonathan, what things are you thinking about that you want to renovate? So go ahead. I'll just throw that out. Whoever wants can answer that. And why don't you all go around?
I would ensure that there's open access to outdoor space. Nature is restorative. And I think in some of our older homes, there's lack of outdoor space, maybe not lack of outdoor space, but accessible outdoor space, and not in a controlled or contrived way. Some of these smaller courtyards to me always remind me of, excuse the term, but prison yards. You know, they're enclosed, they're closed, they're tight. I think people should have an opportunity to be part of their community, to see the school children, going home in the afternoon, to see the school buses, or if you're in a rural area, to see the tractors going down the road. And nature is restorative, and we all need to have access to outdoor space. One of the things about long-term care homes is it's very difficult to get outside without supports. And so there's where the 4 hours of care as an enabler, really to allow people we're Canadians, we know the 4 seasons. So shouldn't be inside from November through to April to the thaw. If you want to put your coat on and go outside in the middle of winter, you should be able to go outside and enjoy it. So we need to be building space that provides that accessibility. But again, the 4 hours of care goes hand in hand with that as an enabler to support people to get outside.
Jonathan, go back to the renovation. I know some of your bids are relatively very new, but still, what are you thinking?
To be honest, I'd agree with Jill. It's that outdoor area. We have one home area that's was designed to thinking of people that are at risk of wandering, and we built a very large balcony outdoor space for them. But then the other home areas, thinking that they'd be able to go down and enjoy the outdoors, that's really changed over the last 18, 20 months, right? They can't just go down with cohorting practices. And so I would agree, like having more access and little freer access for, even second floors, or figuring out how to have them go down in a way that keeps them, if need be, safe in their own cohort.
Jill, I don't think I'm breaching any confidentiality because you are building a new long-term care community in Beaton. Is that correct? Or Jane, I'm sorry.
Yes, absolutely. We're hoping to break ground in the early new year, and similar to what Jill and Jonathan said about the outdoors and nature, and that's certainly huge components. But another element that I would add is co-locating long-term care with other types of housing. So we're going to be building another campus structure. We have had a very successful development with Georgian Village and Penetang, where we've co-located a number of different types of seniors housing with our long-term care home and a community center, the Rendezvous, and it's really worked well for aging in place and socialization, and really bridging, with long-term care and the other types of housing and services. It's been just a wonderful experience. So we're doing it again in our Beaton location. It will be a little bit larger. I think 11 different types of housing components, including an expanded long-term care home, 160 beds. So again, really, in terms of the physical structure, building a community inside a larger community, that really sense of community and social family network, I think, are really important components.
Okay. I'm feeling I'm cutting the structure short because there are far more questions that we can ask, but Ted, you've been very patient, and Ted has some very interesting comments to make on planning for something else other than long-term care, not recognizing that that may not be what happens, but if you plan for it, more chance of it happening right than not, Ted. So take it away, Ted.
Okay, thanks, Keith. Planning for the future really is something that my wife and I, Laurel, and I started to get serious about in our mid-60s. It's amazing how quickly 3/4 of a century for me has gone by. And I'm quite sure that the next 10, 15 years is going to come on just as quick. So I guess a mantra that I have is that I own the future. I can't rely on anybody else to look after it. I have to create what's coming for us and try and make it happen to the best of our possibility, best of our ability. Now, the alternative to long-term care homes, the facilities that we're familiar with, and the models that Jonathan, Jane, and Jill talked about tonight, which I applaud them on the evolution and the changes and the work that they've done. The reality is that for the vast majority of seniors, getting into one of those facilities is not a slam dunk. The last I heard, there's about 30,000 people on the waiting lists to get into long-term care. I believe that's across Canada, but even in Ontario, the numbers are huge. So getting in is not something to be assumed. Aging in place, which is the model that Laurel and I are looking at to create in our own lives, is not a nice to do alternative. I think it's a necessity. The number of people that can get through the door right now into long-term care tend to be limited to those with quite severe cognitive or physical challenges, and they absolutely do not have any alternatives by way of alternate care to be able to stay outside the long-term care environment. That's how I view it. So with my cohort generation, the baby boomers, starting to hit stride in their final chapters of life, that wait list is only going to get longer. So we started planning, and one of the first steps was to look at the type of accommodation we live in. So we definitely wanted to go to a forever home. We've done that here in Victoria Harbor, and we chose a residence that has a main floor master bedroom that has an ensuite. It happens to have a main floor laundry capability. Bottom line is we've taken out as many steps that we can for daily living. The home could be accommodated with an access ramp, either probably through the garage, and that would enable walkers or wheelchair to get in and move around the house. The house is hardwood. It doesn't have carpet. There's a lot of potential for accommodating any disabilities, again, whether they be physical or they could be cognitive down the road. We believe we're in a place that could be adapted. Now, I realize that the situation that I'm in, Laurel is in, is different from many people in the community. So the recommendation I would have is, as you look into your future, think about what type of environment would you have to age in place, recognizing that you're probably going to have to do that out of necessity. Getting into that long-term care home, not so quick. So once we get to a point where perhaps we don't have the independence and the good health that we enjoy today, what type of accommodations can we make? Well, what we would do is create almost a virtual long-term care platform that we would draw on while living in our home. So we would draw on resources available in the community. They might be government funded, they might be private services. We might have to get care to come into the home to assist with errands. We might need transportation assistance. We might draw on students to help out. We live in a community which is very fortunate. We have a home association that provides snow shoveling, lawn cutting in the summer, painting and roofing. So we purposely taken ourselves out of a lot of the burden, the heavy lifting that goes with the home ownership. Others might consider condominiums, where there's a similar maintenance deferral to the property manager. And the bringing in of the services, we don't have a cleaner right now. I'm the cleaner in the house, but there may be a day with arthritis or physical disability. Maybe we'd have to hire a cleaner. We both like to cook, but if we couldn't do it, there's Meals on Wheels. We currently have a vehicle that we're fortunate enough to drive, but if I can't get that license renewed, or if the eyesight goes, we're fortunate that we've got Wheel-Trans and mobility transportation services that are available. Community Reach is a great program that we have in the Huronia area. So the message is that you have to plan and prepare and think about all the services you need to maintain a lifestyle, and then draw on the available community resources or friends or family. Now, we don't have close family to come in and be a primary caregiver, so we would have to hire someone. I used to know it as community care access. I think it's the local health networks now. It's in a state of flux on where you get someone, a personal service worker, to come in and work in the home. But that has to be a resource that gets funded. Jill mentioned putting more funding into community care. I applaud that, and I'll have more to say perhaps in our final wrap up in that way. If you don't have your own home, there are ways of creating what is known as a naturally occurring retirement community. So you might have folks living in an apartment building, or they might be living in an area of town where, if you have others in a similar aging state, in order to get someone to come by and do the cleaning, to do chores around the house, to come in and provide personal care, you might get economies of scale where someone could be hired to come in and work with a number of neighbors, including yourself. So that's another alternative. But the big thing is know what resources are available, so that when you need them, you're not just stressed or in a panic. You can reach out. I know that there's a new initiative through the Ascononia Senior Center and through the New Horizons for Seniors program. There's a woman by the name of Mary Moreau. She's referenced in our brochure. There's a number there. This is a woman who can chase down resources, solve problems, assist with helping you maintain a positive lifestyle and not be lonely and not be at loose ends in your own life outside of a long-term care home. There are virtual resources available, and that's the route that we're going. And that's the route that I would encourage others to think about as an alternative to the long-term care.
Thanks, Ted. Very thoughtful. And I know some of your work has also been referenced. You've done some work with what other countries are doing, and those unique housing arrangements, which depend on a multi-generational or multi-occupancy students in a household to kind of fill in, so that you can actually manage pretty well. So
that's right. The folks in the Netherlands have done an amazing job on two fronts. They have created mini villages instead of a traditional long-term care large facility, where 6 or 7 residents reside with live-in caregivers. And they've got what you would call traditional resources nearby: a beauty salon, a grocery store, a health center where they could do physical exercise or physiotherapy. Now, how that would be funded in a Canadian environment, that's to be determined. But the other program in the Netherlands is having university or college students actually come and live in the facility to provide intergenerational experiences, support, interaction with seniors. The motivation there for the students, they're given free accommodation. It's like a dorm room in a senior center. They can come and go, have their own lives, but when they're around, they're interacting with the other residents. And this has proven very effective. So there are some best practices around the world that I believe people like Jill and Jane and Jonathan and hopefully our government representatives are monitoring and are prepared to take a chance on here in Canada, just to make sure we get the best bang for the buck. But let me talk about best bang for the buck. In a long-term care facility, I believe that the average cost per day, I can't quote the exact survey source, but it works out to roughly $200 a day as the overhead to keep someone in that room in a long-term care facility. There are currently 4,700 people estimated to be in hospitals waiting for a return to home if they can be cared for or rehabilitation. That hospital bed is costing $730 a day. Now, if you take home care with the outside resources and assistance that people can draw on to stay in-house, that works out to an average of $103 a day. So the math says if you've got money to spend, and this is where I'll come and coattail on Jill's comment, if there's money to be spent, put it into services and programs that are community-based, accessible by the population, and let them draw on that and stay in their homes, and then let those that are currently in the long-term care homes be well cared for because they're in physical and cognitive states that really do need specialty care.
Ted, thanks very much for sharing all of this information that now we can take and share with our families and loved ones, because I think it collectively makes a lot of sense, and it just better prepares us. The conversation, the planning is really special, what you've told us. At this point, I'm going to break for a brief time just to say thanks to our sponsors. I think TJ's got a slide he's going to put up. We're continually grateful for the support of the Georgian Bay General Hospital, for Waypoint Center for Mental Health Care, for the Center of Psychology and Emotional Regulation, for Audio Hearing Aid Center, Hillcrest Village Care Center, Mink Insurance, and the Lipton Group. So those 7 sponsors give us enough funding that we can bring this program to our community at no cost. It's a nonprofit, but we very much appreciate that. And when we go back to a live audience at the MCC, there will be no admission charge, just like there used to be. So thanks to those sponsors, and they're always very supportive too. Our next program is called 911 Emergency Services, Advances in 911 Emergency Services, and that's 7 weeks from tonight on Thursday, December the 9th. We have 3 great speakers, one from an emergency department, one from the paramedic services, and one from the police services to talk about what they're doing. And I've somehow got to integrate fire into this conversation too. So I'll be following up on that. So we're looking forward to that. That's 7 weeks tonight. So I'm coming back with a couple of brief questions, and I have lots of questions, but unfortunately they're very lengthy, some of them. So I'm going to try and stick to a couple brief ones. And here's one that arrived today. Dignity in life and death for our frail elderly. And this individual talks about the challenges with death. My experience in long-term care shows me we have a long way to grow in this area. How can we get better at navigating transitioning from our loved ones to the final stages of life's journey? How do you prepare people for that? Because we talked about the short lifespan now in long-term care, and we know the ultimate. So how do you prepare people? How do you prepare your staff for it? Who wants to?
think we talk about it. I think that's the most important thing, is that it's not a taboo subject. I think, I think we'll see, of course, in the legislation, a lot of focus on palliative care and end of life care because of the importance of it. When you come to long-term care, it's something that's just part of our day-to-day reality. And I think we have to work with our staff so that they understand that it is transitioning and that it's part of the normal, it's just part of the normal life process. I think some of the rituals that are in place in long-term care are very important. It's some of the things that we lost that staff talked about that was very traumatic for them with in the pandemic. So, you come in the front door, you go out the front door, and there's usually an honor guard and the staff stand guard as the body passes. And that was eliminated with COVID. And staff spoke to me at length about that. They found that traumatic because they weren't able to have that last act of respect to that resident who they had become very close to through their care. I think other rituals that we do is, preparing the body. Again, staff said that was lost, and, to wash the body and prepare the body and have the family in for viewing. But those are things that we work with our staff with, and we support one another as healthcare professionals through that. And I think working with families is when you come into the home with your resident, we begin to talk about these processes and understanding your wishes. And it's not something that's should not be talked about. It needs to be talked about. But good palliative care, good end of life care does require education and training and ongoing support. And I think that's an area that long-term care will be seeing in the new long-term care legislation. But also, I think we have opportunities in long-term care to do better around that.
Okay. If somebody wants to know about when do you anticipate that 100% of your staff and residents will be fully vaccinated? And I know for your residents now, that means 3 doses, right? So when do you anticipate that is going to happen? I can ask each one of you, just quickly, tell me. Jonathan?
So we expect to be staff 100% vaccinated by October 30th. Our goal was our vaccination policy is in place so that by that date, all staff need to be 100% vaccinated. Oddly enough, resident-wise, we're actually only 99%, and that's because there's still some people that choose not to have the vaccine. So,
and that's not mandated, right? No, right?
No.
Jill?
For us, it was October the 12th. So all our staff in our homes are fully vaccinated, and that means 2 doses. And for our residents, by October 8th, we had offered every resident a 3rd dose. There are some residents who it is their right to refuse, but we also have some newer residents. We have to have 5 months between the 2nd dose and the 3rd dose, and there's some where the timing, so we've got them on the calendar, so they'll be coming up for their 3rd dose, but largely met October 8 deadline to offer every resident a 3rd dose of the vaccine.
And Jane?
So our date is very similar. November 1st, our policy requires all staff to be 100% of staff to be vaccinated. I think we're at 94.5% right now across our 4 homes. The province has mandated it though. As of November 15th, all staff in long-term care homes across the province will be required to be fully vaccinated. So we were pleased to see the ministry come forward with those guidelines to support what we're doing in our long-term care homes.
But we can't forget the work that you've had to do to reach those compliance rates. Because the ministry mandates it doesn't mean it happens unless people like you are reassuring people why we're doing this. So hats off to all of you. So I want to ask a collective question of all 4 of you. And you've all proposed some really good ideas for the future. And, if we were sitting there with a pencil tonight, if I was in the audience, the list would be probably pretty long. So to help the audience with a summary, I'm going to ask each one of you to identify 2 of your ideas that would have a very positive impact on the life of residents and their families in long-term care. Now, in any implementation of new things, some are easy. They're what we call slam dunks, right? You can do it relatively quickly with not a lot of money. And then there are some that are really worthwhile doing, but they take money, they take time, they take good leadership, they take probably cooperation among several sectors, and might even take legislative changes. So I want each of you to think of 2 ideas that could be implemented and would be very good things to do. One that's easy and one that's going to take more time. Who wants to go first?
I'll go first, if that's okay. So public perception, I think, is probably something that doesn't take a lot of money, can change fairly quickly, but I think would make a really positive difference in long-term care. There's been a lot of information in the media. Unfortunately, long-term care residents have been amongst the hardest hit with this pandemic. And, there's been a lot of criticism and negative perceptions. And it's makes it very difficult for staff, for residents and families in long-term care homes, because they know these homes are wonderful places to live and to work. We are incredibly proud of the staff and our volunteers that work in our long-term care homes. And we have endless support from our families. And it really weighs heavily. I think long-term care is probably one of the least understood sectors in healthcare. And it really is a very fulfilling and very wonderful place to be. So, my wish would be for the public to hear all the wonderful stories, the great things that happen in our long-term care homes across this province. So they really recognize these are great facilities that look after some of the most vulnerable people in our communities. So that would be the quick fix, perhaps, and the one that would be a greater investment in resources is really recognition for our healthcare workers in long-term care. Everything from our housekeeping staff to our laundry staff to our dietary to our admin support staff, our nurses, you name it. They are amazing people. You'll have to go far and wide to find a more group of committed, dedicated people that look after our residents like their own family. And I think in the healthcare arena, I think they're not recognized as much as they should be for the invaluable contributions they make. And when the province stepped forward with increases in compensation for PSWs, we were pleased because we know how valuable the work is that they do. So, I think I'd like to see recognition for all of our healthcare workers, regardless of what your role is. They're very special people. They work incredibly hard. And I think they should be valued higher in our healthcare continuum.
Happy staff, happy residents. Follows, doesn't it? Ted.
Okay, well, having been part of a family unit that had a relative in residence, I know that maintaining regular contact with that resident is key to their well-being. So for anyone out there in the audience that has a loved one, a spouse, grandparent, parent, double the amount of time you're in touch with them. You can do it in person now. You can do it by Zoom. You can do it by phone call. If it's in person, the human touch is so important. So that's a quick fix. That's easy, and that makes life that much better for the residents. And while you're at it, say thank you to all the staff that do the great work and support. So I'm coattailing on Jane's point. The bigger picture is a kind of a back entry into helping long-term care residents, and that's by reducing the need for more long-term care beds and by not putting as many people through the front door going into long-term care by making sure there's sufficient government funding for community support programs and services. If you take the same amount of money, the hundreds of millions of dollars, and you take that and you put it into community-based services and aging in place home care, you will service more people than you will by building more long-term care bricks, mortar, and beds. Now they're needed, don't get me wrong, but if there are more people being well cared for and having a quality of life in their home, in the community, you've then taken the pressure off the long-term care facility and they can give better care to the residents that are there.
Jonathan?
And, I'm actually going to piggyback on Ted and Jane and say, the government funds and they provide regulation, but it really takes the community to come in and support, as they've said, support the staff and support the residents through this journey of long-term care. So, we certainly, I certainly invite our families in now that those that are vaccinated and families and volunteers, and just come in and just spend, I think somebody's already said it's not, we're not looking for you to spend 8 hours, just come in and spend half an hour or 20 minutes with somebody. And, we always say you'll gain as much as you give in time and reward from just spending some time with people that really are just looking for that human touch, that just a conversation or even just a walk or a stroll around. So I would just, as I said, piggyback on that. And then with another suggestion is with the pandemic, as I mentioned, the resident support aid, there was funds that went into training, an online training program for these resident support aides. And I think that's something that should be looked at expanding so that maybe PSWs and food service workers and others that need the certificates can, homes can hire these people and then train them on site in home. And I think that we've made steps down that road, and I just think that needs further funding and further push to make it a little more comprehensive what kind of training we offer in our homes.
Jill?
Something that we
I
can
put you in the tough position at the end.
I think something that we can all commit to is person-centered language. And I think that's something we can all start to do tonight. And I'll just give an example. We often talk about long-term care homes as beds. Beds are commodities, but we have to remember that there's people in those beds. And so just turning the words around in one sentence. So we talk about, I have a 160-bed long-term care home. Change that to, I have a home for 160 people. In one sentence, you turn that around and you start to turn the focus more onto being person-centered. So I think that's something we could all commit to tonight and begin to confront ageism that way. And I think secondly, I agree with what everyone has said around changing the definition of long-term care and moving it away from just an institutional definition and more to a continuum of services. The necessary conclusion to the aging trajectory does not have to be long-term care. And with that, I would like to add one more point, if I could, is embed the role, the definition of the role of the essential caregiver into legislation. We understand the importance of the essential caregiver to not only the resident, but to the home itself. And that needs to be enshrined in legislation.
So just pursue that a little bit farther. Does that mean when I think of the embedding some of these services at one point into legislation, it was to make them work so they couldn't go off job on a strike or on a, they had to continue to work. So what does yours look like, Jill?
So by the essential caregiver, Keith, I mean the essential family caregiver. We sort of dropped the family from it because it can be anybody of importance to a resident, but
Yep.
we lost those individuals early on in the pandemic in wave 1 and wave 2, and they were welcomed back. But we understand the importance role of family and those people of importance to residents. And I don't think any of us would want to see that lost again. So I think the role that those people of importance play to individual residents needs to be in legislation. And I think I would extend that to say the important role that those people play in our long-term care homes as well.
Okay, I have one more question, and then we've got to close for the evening. It seems to have gone so quickly. Maybe just one of you wants to take this. Are the symptoms of dementia mostly the result of boredom, loneliness, and life without meaning? Which, when I think of the common view of long-term care, of somebody sitting in a wheelchair by themselves in a room staring out the window and no meaningful reason for being there. Does that actually make dementia worse? And then, Jill, what you're planning to do, is that meant to make dementia better or slow it down?
Absolutely, it makes it worse. And often you see, because it is worse, the addition of some very harmful medications that are added on to control what's known as behaviors. But, people are not a behavior. The day is the program. And if you've got the right people and the right culture, nobody's, sitting in that wheelchair with their head down, staring at their feet. People are engaged to the level that they want to be and to the level that they can, again, doing things that are important to you, having meaningful activity, having a purpose in life. We all need a purpose in life, whether that's doing the laundry or peeling the carrots for the evening meal, or maybe we've got to do some cleanup, or we're doing some gardening, or we're just going to be outside and enjoying nature. Like that's what's important to us. And so nobody should be sitting alone. And I think you're referencing, Keith, that vision sometimes that we see shared out about long-term care with people lined up in wheelchairs against a wall with their heads down, staring at their feet. But when you lift the drug fog, those medications are not on board. People are engaged in their life, and when you've got the right staff, you've got the right culture, and again, this average 4 hours of care, it's a great opportunity to enable that, to have the staff available. People are happy, and people are engaged in their lives and in their life.
Jill, thanks for those final comments. It's been a pleasure to host this event. Thank you to our audience for watching and learning with us, because we all learned something tonight. If you want to let us know what you thought about the program, again, that address, MCC_our health at the website. You've got it on your screen at outlook.com. Please take the opportunity to watch the program again, or to send it to your friends. We'll send the link out very shortly. The one good thing about the Our Health programs is they are all on display in video, so they're easy to go back to. And I know I need a refresher course frequently. I really want to say, though, a big thank you to our 4 speakers. You've been a pleasure to work with, each one of you. Jill, you're so well connected with an incredible amount of experience. Jonathan, you know firsthand what goes on in a long-term care home and how to make it good. Jane, you're taking charge of so many aspects in Simcoe County, and I applaud you for the work that you're doing with the new long-term care home builds and incorporating so many of the ideas that we've been talking about tonight. And Ted, passionate description of your hopes for the future, ideas that move well beyond simply adding new long-term care beds. So thanks to the 4 of you. Thanks again to our 7 sponsors. And we'll see you again on December 9th for advances in 911 emergency services. Stay tuned for 2020.
When you're online, Rogers TV on YouTube shares news and events from your community, like messages from local leaders, updates on the latest health news, local business presenting their new offerings, and how our local communities are working their way through these unprecedented times. Visit and subscribe to Rogers TV on YouTube for the latest local information.
I'm Mallory, and I was walking home one night when an impaired driver hit me. He had been overserved in 2 bars before getting behind the wheel. If the servers would have called him a cab instead of serving him more alcohol, my life would be the same as what it used to be. I think servers play the biggest role in keeping us safe because it's up to them what state the person's in when they leave. Refusing service isn't personal, it's the law.
This is Rogers TV, Midland.
Hello and welcome to A Day in the Life. My name is Fred Hacker. I'm your host and your community producer. This is program number 117 in our series. And I'm excited to tell you that this program kicks off the 10th season of A Day in the Life. If, however, you happen to be watching for the first time, then we welcome you and we invite you to go to the Midland Cultural Center website where you can find about 50 or 60 of our previous programs recorded. You just click on Community Programs on the MCC website and then click on A Day in the Life and the programs will be available to you. Well, as we always do, we want to begin this program by thanking our season sponsor. Our season sponsor, once again this year, is Bales Dishaw Halloway Financial Advisors.